All right, thank you, Dr. Lee. So hi everyone, for those that don't know me, my name is Samrad. I'm one of the R1s in the UBC program. I'm going to talk about small renal masses today and whether surgical approaches matter in terms of patient outcomes and if there's any benefits to one approach versus the other. So there's three key objectives that I want to talk about today. I wanted to review indications of radical versus partial nephrectomy and look at outcomes of radical versus partial nephrectomy. Is there a benefit to doing one versus the other? Certainly we see both happen at UBC at the different centers, so is there really an outcome difference? And then I'm going to kind of switch gears and go into looking at the radical and the partial nephrectomy in its own entity and look at open versus minimally invasive approaches to each and see what the data shows us right now in terms of outcome for patients. The first part of my talk, as I mentioned, I'm going to talk about partial versus radical, and these two objectives are kind of hand in hand, so I'll get to it right away. So localized renal masses, so as is well known, we have an increase in incidence of finding these renal masses on imaging. Patients go to emergency department with abdominal pain, they get a CT scan, they see a mass incidentally, referral to urology. This is happening more and more because we have better imaging that's available, and it's really over the past couple of decades that our approach to these masses have changed. Previously, they were all assumed to be malignant, they were assumed to be aggressive, and they were treated as so. But now our understanding is that these lesions could be quite heterogeneous, and therefore there's multiple management strategies that are available. You can watch these lesions if they're within a certain size and characteristics. There's ablation therapy that's an option, or ultimately the most sure way to get rid of them is a surgical approach in doing a nephrectomy, be it radical versus partial. And as you can see, about 1 in 5 of the solid enhancing clinical T1 renal masses are in fact benign, and there's multiple characteristics that you have to look at for these lesions to assess how dangerous they can really be, with size being a key characteristic. So we're doing more and more partial nephrectomies, but there's not really there's not a lot of absolute indications. Bilateral RCCs are certainly an indication. If you have a solitary kidney with RCC, you obviously want to maintain as much nephrons as possible. And then we have a whole bunch of relative indications. So if you have a unilateral cancer with an abnormal contralateral kidney for whatever cause it may be, then you see partial nephrectomy be chosen as the option. And certainly partial nephrectomy isn't a new concept. It was started in 1890 by Vincenz Cerny, but unfortunately due to increased morbidities at the time, it was kind of abandoned until about the 1950s, where a gentleman named Vermeulen came up with the concept of peripheral encapsulation of renal neoplasms that could be excised while leaving behind normal parenchyma. And as our imaging has gotten better to identify these and the vascular surgery is improved, we're able to minimize ischemic renal damage, which is improving our outcomes with nephron-sparing surgeries. So what's the benefit of partial nephrectomy? Certainly they're nephron-sparing, but so what? What does that do? There's some discussion of whether it decreases the likelihood of developing chronic kidney disease. Does it decrease the likelihood of having cardiovascular events or other health-related outcomes? And those are the questions that I hope to answer by the end of my talk today. So in the year 2000, a group in Rochester, Minnesota looked at outcomes of radical nephrectomy versus partial nephrectomy, Lau and his team. And they tried to basically put two groups that are fairly equally matched with respect to the pathological grade, staging, tumor size, age, sex, and the year of surgery. They wanted to look at early complications, postoperatively, proteinuria, and further look at any significant recurrence and metastases 10 years down the road. And what they found from the patients that they were able to follow up, and the patients that were there were the ones that are still alive and still they could still assess, they found no difference in the overall survival or cancer-specific survival. Similar rates of contralateral recurrence and metastases at 10 years, and there was certainly no significant difference in early complications. But what they did find is that in the radical nephrectomy group, you have an increased risk of developing chronic kidney disease, which they defined as creatinine being more than 2 milligram over DL, which is around 177 in our units. But the best way to assess for chronic kidney disease is the EGFR and not the creatinine. So I'll delve into that a little bit more. And why is that significant? Why is the creatinine going up significant? So there was a study that was done in 2004 looking at patients with difference in creatinines and trying to assess whether their health outcomes will be different. And this group looked at the Kaiser Permanent Renal Registry, which is about 35% of the adult population in the Bay Area, and they basically had access to outpatient creatinine of patients in the area. And so they would take their creatinine and then follow them over a long period of time and see, with the changes of their creatinine, with development of different disease, how their health was impacted at that point. And these patients had to have had no previous dialysis or kidney transplant and be alive on the index date. And what they found with the patients that had followed median time of about 2.84 years, about 20% of them disenrolled, but they were actually found to be the more healthier group with better kidney functions. And what they actually found is, comparing to their standard, which they defined as being a GFR of 60 and above, that's what they define as normal. The lower your GFR went over the years, the more likely you are to develop multiple diseases. So what they found, for example, after they adjusted all the socio-demographic values, they found that if your GFR drops from the above 60 cohort to the 45 to 59, that you're 43% more likely to develop cardiovascular events. And if you drop that to comparing the over 60 group to the people that are within the 15 to 15 or less than 15, pardon me, then it goes to about 343% more likely to have events. They found that these people are significantly more likely to present to the hospital for different reasons, and they're significantly more likely to have death from whatever reason. So really, following their GFRs over a long period of time was a fair estimation from their study as to their outcomes in the long term. How does that apply to us? So a team, Huang et al. Looked at patients from the prospective database where they followed 2,000 patients from the Memorial Sloan Kettering Cancer Center. And what they wanted to do is look at these patients with a baseline creatinine and see how their creatinine and their kidney function is after they have surgery. And they looked at it after nephrectomy, how it can affect it. So post-operative estimates of GFRs weren't updated until about 4 more weeks after the nephrectomy. And what they wanted to see is, after they have their surgery, how often these patients are going to develop eGFRs under 60 or under 45. And they looked at under 45 and under 60 because they looked at under 45 as being more significant chronic kidney disease, and noted that you're more likely to have negative health outcomes if you're under 45 versus under 60. So what they found is, comparing partial and radical nephrectomy, about 70% of the patients who had a radical nephrectomy developed an eGFR of under 60, whereas about 17% of the patients who underwent a partial nephrectomy developed a new eGFR of under 60. The median follow-up was fairly similar in that radical nephrectomy was every 4 months, whereas a partial was every 6 months. And this is a pretty significant finding in the sense that there's a significant rise in the difference of developing a new eGFR under 60. And they also calculated the 3 and 5 year probabilities of freedom from new onset of eGFR less than 60, and that was found to be 80 and 67% respectively for partial nephrectomy, and 35 and 23% for radical nephrectomy. Then they looked at the likelihood of developing an eGFR under 45, and again, they found 36% of their patients, about 1 in 3 of their patients, developed a new onset of eGFR under 45, whereas only about 3% developed a new onset of eGFR under 45%. And again, their 3 and 5 year probabilities of freedom from the new onset of eGFR under 45 was 95 and 93% in the partial nephrectomy group, compared to 64 and 57 in the radical nephrectomy group. Then Kim et al. Did a meta-analysis looking at multiple different aspects of comparing partial versus radical nephrectomy, and they did a quick analysis from 9 different papers on likelihood of developing chronic kidney disease as well. And similar in line to what I mentioned, they also found that there's a 61% risk reduction in developing severe chronic kidney disease if you had a partial nephrectomy versus a radical nephrectomy. Now, this is kind of painting a picture that partial nephrectomy is significantly better than radical nephrectomy, but at the end of the day, the main goal that we look at is patient outcome in terms of their outcome with respect to their cancer. Are we treating these cancers? Is there a difference between outcomes when you go with partial versus radical nephrectomy? Well, not the only matter, but at the end of the day, we want to make sure that we're treating the cancers too, because if we're not catching the appropriate tissue, and if we're not taking out the parts that are directly affected, then severe kidney disease may not be their biggest issue at the end of the day. So we want to make sure that we're taking out the cancer effectively, and then kind of looking at the down the road effects a little bit later on. Fair question. So this group, Petard et al., they looked at a retrospective analysis of about 1,500 patients from 7 international centers. It was in France, Italy, the Netherlands, and in the US. And they compared partial nephrectomy versus radical nephrectomy. And they looked at T1A versus T1B disease. And they wanted to really look at cancer-specific survival of these patients for T1 and M0 renal tumors. And what they found that there was really no difference in recurrence, distant recurrence, or local recurrence when you look at partial nephrectomy versus radical nephrectomy, be it T1A tumors or T1B tumors. Now, they didn't have the data for every single patient that was originally enrolled. They only had 544 patients that they were able to follow and extract the data for this, but still, from a cancer perspective, they were quite comparable. And what they found is that for patients with T1A tumors, there was no significant difference with cancer-specific death rate of partial nephrectomies when compared to the radical nephrectomies. And again, same theme with the T1B tumors, where they found there was no difference in cancer-specific death rate between the patients. In Bedalto's team in 2011, they looked at about 11,000 patients with T1B renal cortical tumors, which they identified in the SEER registry that underwent a partial nephrectomy and radical nephrectomy. This was the data from multiple different parts of the U.S. And within the population, they looked at individuals who had no nodal or distant metastases. They were over the age of 18 and had tumors that were identified to be 4 to 7 centimeters in size. And they wanted to look at cause of death as defined to their SEER-specific cause of death and patients who did not die from undergoing this procedure. And the median follow-up was about 41 months for the radical nephrectomy and 33 months for the partial. And again, similar to the last study, they found that from the Kaplan-Meier analysis that radical nephrectomy and partial nephrectomy had no substantiated difference in overall survival based on the type of surgery they received. And the 5-year survival of the partial nephrectomy was 82.5% compared to 85% in the radical nephrectomy. Now, there's a lot of data suggesting similar outcomes with respect to the cancer treatment, but there was one significant prospective study done in 2011, and that was the Van Poppel team, who did a randomized phase 3 study and compared the differences between nephron-sparing surgeries and radical nephrectomies. And they looked at 541 patients with masses under 5 centimeters that were randomized to nephron-sparing and radical nephrectomy. And the primary endpoint was overall survival, and secondary, they wanted to look at disease-specific survival, progression, and surgical side effects. And the caveat to these was they had to have a normal contralateral kidney. So they found that in the nephron-sparing group, there was more of a laparotomy approach, radical nephrectomy, more of a thoracal laparotomy approach. More lymph node dissection was seen in the radical nephrectomy group. Hilar clamping median time was about 20 minutes. And interestingly enough, not everyone got a node dissection. That was noted in their findings as well. Now, this was kind of different to what I originally expected, but what they found that there's slightly higher complications in the nephron-sparing group, and they found that fistulas were only seen in the group that had the minimally invasive approach. They were more likely to have perioperative bleeding, and with respect to intention to treat and having overall survival, they found that there was a slight benefit overall to the cohort that they had with respect to radical versus nephron sparing. The radical had a slight benefit, but when they looked at the RCC group as a whole, in its own nature, they found no difference in between patient outcome with respect to their overall survival. And that's a pretty substantial finding, given that it was a prospective study and they were looking at overall survival for these patients. And looking at these patients in a longer term, they found that there were 12 cancer-related deaths, 4 in the radical nephrectomy group, 8 in the nephron-sparing group, and the progression of the cancer was comparable within the radical nephrectomy versus the partial nephrectomy. This was an interesting kind of side finding in the sense that they followed these patients for quite a few years, and they found kind of what we saw earlier on in what I mentioned that you're more likely to have a bump in your creatinine if you had a radical nephrectomy versus a partial nephrectomy, but they noted more cardiovascular deaths in the nephron-sparing group compared to the radical nephrectomy group, which is kind of opposite to some of the earlier data and what had suggested. Authors of the paper didn't have a good explanation for this. Certainly, they weren't looking to investigate this, and it just speaks to the fact that we need to perhaps have a look in a more prospective setting as patient outcomes when not related to cancer survival with radical versus partial nephrectomy. So, yeah. Yeah, I just, based on the papers that I saw beforehand, I would have expected.
Just trying to figure out why you're surviving.
Yeah. Yeah, I just, like, because of the papers that I read before that, I just expected such a vast difference in the other way around, partial nephrectomy, to have significant better outcomes with respect to cardiovascular health. But I didn't add that part to this, no.
There is a long-term development. Sorry, 5 years.
Yeah.
You've got to be looking at it because you went back. You have to. Unfortunately, I think residents now mention the name of the staff and all the staff we knew about from Andy Novak from 20 years ago. But it's not like it's new data. You also have to know what happened in surgery. Is that when laparoscopy ramped up, they threw out the baby with the bathwater. They stopped. There was a precipitous drop in practice, and there was a lot of renal waste occurring because radical, everybody wanted to. There was less complication, and then what's happened is that it evolved to the lap partial, which a lot of them have converted to lap radical. And now we're into a stage in nephron sparing surgery, and obviously surviving that.
Yeah.
And it goes up. But then we're in a stage right now where perhaps we're throwing out the baby with the bathwater, and that we're doing, like robotic skill setting for lap. Sparing surgery, but is it actually high nephrometry score patient? Is it really the best option? And when you talk about the bleeding, if you go and listen to reporter he'll say the reason why we have a lot is that we were still learning is that they were doing a renal lab. That was a fact. That pure lab robotic.
And basically what you mentioned, this is the AUA recommendation. It's a bit of a busy slide, but they essentially say they would recommend partial nephrectomy for all the surgical approaches unless it seems to be too challenging to go ahead with that approach. And then at that point, they recommend the radical nephrectomy. So this is just going to take a turn for the second part of the talk that I want to talk about basically minimally invasive outcomes versus open outcomes for radical and partial nephrectomies. And seeing it's fairly new data that comparing the different approaches of open versus minimally invasive. So I want to assess to see if there's any difference that's been seen early on. And so open kidney surgery can have more postoperative discomfort and certainly result in muscle volume change. And you can have larger incisions which can affect the patient's satisfaction with their body image and incisions that they have, whereas minimally invasive might have cosmetic advantages and increase patient satisfaction. The first one that was done with respect to a nephrectomy took 7 hours. Like you mentioned, Dr. Patterson, the learning curve has been something significant to note here too, but patient recovery was significantly improved. So how about the long-term outcomes for the patients? So first I'll talk about partial nephrectomy and looking at open versus minimally invasive. So this is a study that they looked at a nationwide inpatient sample, and they compared to patients that were over 18 years old with a primary diagnosis of kidney cancer and looked at intraoperative and postoperative complications that were monitored. Intraoperative was defined as surgical lacerations of the bowel, ureters, nerves, or vessels. And postoperative, they looked at cardiac events, respiratory events, vascular events, and basically anything that they could find, postoperative infections, wound infections, etc. And they also looked at the likelihood that a blood transfusion will be required, the length of stay of the patients, and in-hospital mortality. They performed, from the data, they had over 38,000 partial nephrectomies that were available. 2/3 of them had an open procedure, with the rest being minimally invasive. And what they found, the patients undergoing minimally invasive partial nephrectomy were significantly less likely to have to require blood transfusion. They were less likely to have postoperative complications, and they were less likely to develop infections, and much less likely to stay in hospital for a longer period of time. Interestingly enough, they found that it was only in the robot group that they had significantly less likely to develop respiratory, genitourinary, and vascular complications. The NEPHRECTOMY group, the National Surgical Quality Improvement Program, also looked at over 13,000 patients who underwent a partial nephrectomy over a 5-year course. And interestingly enough, in this case, about 2/3 of them had MIS procedures, about 1/3 had open. They looked at 30-day complications and perioperative outcomes for these patients. And they found pretty much down the line a better outcome for the patients who underwent MIS. They were less likely to have complication at 30 days, not require blood transfusions, reoperation, readmission, and lower 30-day mortality rate, and stay in hospital for a less period of time. When they did a multivariate analysis, once again, it was the same results. But it is important to note that for this data, the baseline characteristics were quite significantly different with patients who underwent open versus minimally invasive. The open group was more likely to have a higher ASA, more likely to be diabetic, have COPD, hypertension, or have renal failure prior to the surgery being performed. This is a project that I worked with Dr. Black on when I was a medical student. That's why I didn't put a name. I felt awkward putting my own name in the presentation. But we basically looked at individuals with the first occurrence of clinical T1 renal mass, and we looked at 680 patients from Canadian Kidney Cancer Information System from the year 2000 and 2015. You see that about 313 patients had an open procedure, 338 laparoscopic, 29 robotic. And our goal was to assess which approach can achieve the trifecta the best. And the trifecta was defined as having negative surgical margins, minimal loss of renal function, which we defined as less than 10% decrease in eGFR, and absence of urologic complications. The pre-op estimated GFR was calculated using creatinine from 12 months prior to the surgery, and then we compared the eGFR 12 months after the surgery. And I've highlighted the T1B group here just to note that the open approach dealt with more complicated renal masses in terms of the size, more likely than the other approaches, laparoscopic and robotic, were mainly T1A, whereas there's a significant portion of T1B having open approaches. And what we found was there was no real difference in achieving a trifecta when looking at open versus laparoscopic versus robotic. The biggest barrier to achieving it was the drop in the eGFR, but this was comparable across the three approaches. There was no significance in the findings, so you're not more likely to achieve the trifecta doing one approach over the other, as per our findings and looking at the eGFRs 12 months before and 12 months after. At the end of the day, though, a lot of the decisions made with respect to what happens in anything, really, not just medicine, is the cost and which one of these approaches are more costly. And this was a meta-analysis done of 29 different centers, and they wanted to look at OR costs, anesthesia costs, room and board, medication costs, and lab and pathology services. And they also included for the robot the price of purchase for the Da Vinci and the maintenance fees, which, as you can see, are quite significant as well. And OR time was $12.90 a minute, $772 an hour, and average pharmacy costs are noted there. And you can see that it's actually more for the open and compared to the laparoscopic that they note. And primary equipment cost determinants for laparoscopic and robotic also include disposable laparoscopic instrumentation such as Visiport device, suction irrigator, hot shears, 2 large needle drivers, etc. So there's more costs for the minimally invasive compared to the open with respect to the supplies that are required. And they also looked at the cost of perioperative blood tests, blood bank, chemical analysis of drainage fluid, basically everything they can to compare the cost of the matters. And what they found is that the overall cost showed that the robot was more costly, not because the patients had more complications, but simply the fact that the surgical equipment was more expensive. And that was the driving factor to make it the most expensive approach. Whereas when you look at laparoscopic versus open, the reason the open ended up being more expensive than laparoscopic was simply because they were more likely to be in hospital for an extended period of time compared to the laparoscopic. So they accumulated more costs, and that was the main reason why they came second compared to the laparoscopic group. Yeah.
Do you know if surgeons?
They actually mentioned, they mentioned in their study actually that the hospital charge data did not include profit margins. They did mention about the surgeons, but I think it was each site had a different cost, so they didn't have a standardized cost across the 29 studies that they looked at. So I didn't have a oh.
Sorry, not. It's all that we all.
You know, if you go make your process.
Right.
They used the University of Texas Southwestern Medical Center OR Administration and Billing Office. So I'm guessing they tried to standardize it and look at the different sites, but they didn't get the specific, from what I recall.
Well, there may be hospitals being on the robot, but
Just switching gears now, just look at the radical nephrectomy. And this was a bit tougher to find data on, and I guess it speaks to the fact that we're doing more and more minimally invasive procedures compared to the radical. Sorry, we're doing more of the partial nephrectomy compared to the radical. The surveillance epidemiology and results program in the U.S. data and the Medicare program was assessed, and they looked at, interestingly, only patients over 65 that had kidney cancer over a decade, and they wanted to look at the overall survival and RCC-specific survivals, and also look at the perioperative outcomes with respect to these patients. So if they had any MI, strokes, had developed any DVTs, PEs, required admission to ICU, had any infections, etc. They used a propensity score to adjust for differences in the baseline characteristics of these patients. And what they found was minimally invasive approach showed a lower all-cause mortality in the first 7 years, but strangely, the benefit kind of disappeared after the 7 years. And patients that had tumor size of 4 to 7 centimeters had a lower all-cause mortality with the minimally invasive group. And furthermore, people that are going under minimally invasive surgery had a lower cancer-specific mortality following surgery. Now, the MIS patients were also less likely to experience perioperative complications. This was, for example, developing a DVT, respiratory complications, infections, sepsis. As a whole, it was quite comparable when you look at all the postoperative or perioperative complications. The minimally invasive were much less likely to develop this. Lee's team recently looked at survival rates and postoperative complications in patients with T2 RCC, so having more than 7 centimeter lesion, and they had about 2/3 of the patients have an open procedure versus about 1/3 that underwent a laparoscopic procedure, and they were looking at overall outcomes in terms of the patients and postoperative complications, and what they found was that there was no difference in the progression of the disease. There was no difference in the cancer-specific survival or overall survival. And postoperative complications, interestingly in their studies, was not significant across the two across the two fields, across the two approaches. A retrospective study, now we're going to a little bit more advanced, larger size masses. So they did an analysis of PT3, T4 RCC who underwent open versus laparoscopic. And they saw 172 patients that met the criteria. And again, kind of similar to what we've seen, the MIS demonstrated lower likelihood of having estimated blood loss, lower rate of requiring transfusion, and shorter length of stay. The median follow-up with these patients was 32.8 months and showed no difference in overall survival.
That study piece out.
Not.
Because, if you look at the data from our hospital, like the open radical, so there's usually like they're taking out the kidney plus some other stuff.
Yeah.
And that patient have a higher perioperative could go into surgery compared to the renal science fat is up 3, which has length of 2 days is fine. That's usually see.
They kind of just, the results were comparable. They just kind of said, these are the results of PT3, they're comparable. These are the results of PT4. There wasn't any significant difference between the two. But I understand what you're saying in the sense that it's more complicated the latter. So putting it all together, does the surgical approach matter? Well, we see that radical nephrectomy and partial nephrectomy have similar oncologic outcomes, but there's quite a lot of data that suggests that partial nephrectomy can decrease the risk of developing other health concerns. But there's been no randomized trial, there's been no good prospective study to look at just those aspects. Van Poppel talked about the overall cancer survival when you look at the two different studies, but I think more studies are needed to actually look at if there's a difference in developing other health conditions prospectively. And while we see no oncologic benefit between open versus minimally invasive group, we do see some perioperative benefit in the minimally invasive surgery. But again, similar to what I just mentioned, there's no great prospective data available for this fact either. And it's a matter that it's quite fresh. It's more of an interesting factor in the sense that there wasn't a ton of data, but it's becoming, there's a lot of things that I saw that are coming later on in 2018. It's something that's looked at more and more to compare open versus minimally invasive. And this, I know I didn't do a talk on kidney stones, but it was kidney related and I found this, so I just had to add it on. And I just want to thank Dr. Black and Dr. Ang for directing my resources and projects. So thank you.